Good afternoon and welcome to this session, What's the Play Coach? The Pharmacy Team Playbook for CF, otherwise known as Team Pharmacy CF 101. My name is Brittany Wright and I'm a clinical pharmacy specialist at the University of Iowa Hospitals and Clinics. This is my co-referee for today, Carissa Kam, a clinical pharmacist practitioner at UNC Health in Chapel Hill. As we know, highly effective CFTR modulators have continued to revolutionize CF care. In today's session, we aim to offer new and veteran pharmacists an overview of current treatment regimens, as well as provide insight into medication changes expected in the post-modulator era. Pharmacy care team members will learn how to best maximize their ever-changing roles within the medication management team and access. And if you're not a pharmacy team member, welcome to the game. We hope you'll learn a little bit about what pharmacy team members can offer the CF patient and team and connect you with potential resources to help fund a position. Here are our disclosures. And today's learning objectives include discussing current cystic fibrosis pharmacotherapy and understand roles in therapy, analyze new and changing roles and responsibilities for pharmacists and pharmacy technicians, as well as formulate strategies to navigate current medication access challenges and foster medication adherence.
Great. And we have a wonderful lineup of speakers today. So first up, we have leading off Dr. Wendy Bullington presenting Med Madness, What's in Your Bracket, a review of chronic CF medications. Next, we'll have Dr. Stacy Peters presenting Playing the Infield, strategic review of inpatient CF care. Then third, we'll have Dr. Taylor Imburgia presenting Special Teams, maximizing the role of the CF pharmacist. And finally, our closer will be Billy Simonson, a certified pharmacy technician, presenting Leading and Assist, the role of the CF technician in medication access. Throughout this session, we do encourage you to engage by submitting questions into the Q&A portion of the app. So if you find our session, DG03, and click on session details, you'll see the icon for Q&A at the bottom, and you can submit your questions there. If other audience members like that question, you can upvote that, and at our Q&A sessions halfway through and at the very end, we will ask our wonderful speakers some of these questions. If you are feeling brave, though, you can step up to the plate right there, also known as the mic, and come up and ask your questions. Because this session is being recorded, if you do have a question, we do ask that you come up to the mic so that the folks who are listening later on online will be able to hear that. All right, so with that, we have our first lead-off speaker. And so we have Dr. Wendy Bullington, and she is the inpatient and outpatient cystic fibrosis and NTM pharmacist at the Medical University of South Carolina. She completed her PharmD at MUSC and then completed a 2-year pharmacotherapy specialty residency. She is board certified in pharmacotherapy and spends the majority of her time dedicated to direct patient care. She is very involved with the Cystic Fibrosis Foundation, having served on several committees. She is also an adjunct associate professor at the College of Pharmacy. So Dr. Bullington.
Thanks, everyone. I appreciate that introduction. Y'all can still hear me okay? Awesome, thank you. So, as they mentioned, I've been taking care of adult patients with cystic fibrosis since 2005 and pediatric patients with cystic fibrosis for about the past 4 years. So my topic today is just in time for basketball season, but it's Med Madness, What's in Your Bracket, the pharmacy team playbook for cystic fibrosis. I don't have anything related to this presentation to disclose. And so as we all know, people with CF, it's complicated for them, life, in many different ways, from the number of therapies they take to how long it takes them to actually complete those therapies. And we know it's a goal of the Cystic Fibrosis Foundation to not only find a cure, but to also help these patients sustain their daily therapies in their day-to-day living so they can maximize their health benefit while also being able to do all the things that they really enjoy. Medication management is a way that we as pharmacists can help them do that. And for today, our objectives are to summarize commonly used cystic fibrosis medications and identify useful resources and guidelines, to evaluate emerging literature regarding post-modulator medication management, and then redesign pharmacotherapy care plans to best meet the needs of changes in chronic CF management. I'm going to use a lot of different abbreviations throughout this presentation. You guys probably know most of these. The biggest thing I wanted to comment on is I will be calling elexacaftor, tezacaftor, ivacaftor, ETI throughout the remainder of the presentation. So let's start with the patient case. And this is a patient I've known since I started my job in 2005. HC is a 34-year-old female who's homozygous for F508del. Her CF is complicated by bronchiectasis, reactive airways, CF arthropathy, sinus disease, and pancreatic malabsorption. Her cultures in the past year have grown MRSA by swab. In the past, she had a history of Pseudomonas in her cultures, but since starting modulator therapy, she hasn't been able to produce any sputum. You're in clinic, and the medical resident is unfamiliar with CF, and he asks you, why is she on so many different medications? So here's a list of HC's medications, and as you can see, she's on a lot of the medications we see our CF patients on. I do want to comment that she is on enzymes with meals and snacks. She's on full-dose ETI therapy, and from a nebulization standpoint, she's on albuterol, Dornase alpha, hypertonic saline, and she also does budesonide and formoterol BID. So what's in our bracket? There are many different classes of medications we use for patients with CF and the complications of the disease. For time today, we're going to focus on just a few: the CFTR modulators, the mucolytics, inhaled antibiotics, and pancreatic enzymes. If you aren't as familiar with some of the other medications on this list, I do have two great references at the bottom of this slide where you can read more in depth and find more information about those. So this is always one of my favorite slides for learners and as I geek out as a pharmacist about how the genetics works in our patients. But we know that the mutations in the CFTR genes can be divided into several classes. And it's important to know for our patients which specific genetics they have to determine which mutations, or not mutations, but which modulators they should really be on. On the far left-hand side here, you can see in patients without CF, we know that the CFTR gene encodes for the CFTR protein, which will assist in regulating wire and ion transport. Then if you look at just a couple of these different mutation classes, you can see in class 1, these unfortunately are patients where CFTR modulators won't work at all. Class 2 mutations, including the most prevalent, so our patients with delta F508, we know that there's defective processing and trafficking, and that's why we use not only 2 different correctors for these patients for the processing and trafficking, but also a potentiator at the cell surface. And then lastly, just to talk about one more, we have our class 3 mutations, and at that point, we have defective channel regulation in our patients. So I stole this slide from an article that I thought was really interesting, and it was published in 2020. And what it really looks at is where do the different medications work for our patients. You can see here on the top row, you have your potentiators that increase the function of the CFTR channels on the cell surface. In the second row, you have our correctors that again improve the processing and delivery of the protein to the cell surface. And then in the bottom row here, this is areas of research where we're seeing where maybe we can do new things for our patients that have class 1 mutations. So there are 4 specific medications that we use within the CFTR modulator family, and we're going to talk a little bit about each one of them. So let's start with ivacaftor, which is a CFTR potentiator, and it's exciting because it's FDA approved now down to 1 month of age. As you probably remember from learning in pharmacy school, we know that medications are first approved in the adult population, and then once they find safety studies, they then go to younger patients to see how they do on the medication. We saw in these studies that patients 12 years and older had improved FEV1 of about 10%, improved quality of life, and they were able to gain weight to really help with their overall well-being. I always like to give a caveat too, is this was really the change for those of us that have been in CF for a long time, where we started to see our patients, even though it was a small population, we saw them really start to have hope that these medications could really make a difference in their life. In the younger children, again 6 to 11, we saw improved FEV1, improved quality of life, and weight gain. And then finally, in studies less than 6 years of age, it's hard to measure lung function, but we do know that the safety profile is similar to what we found in adults, and we do also know that they did have decreased sweat chloride once they were started on this agent. So lumacaftor ivacaftor came next, and this is a corrector and a potentiator. And we were really excited this year as it was FDA approved down to 1 year of age. Again, in adults, we found that it did improve FEV1, not to the same extent for our patients that were on ivacaftor, but 2 to 3%, and also decreased pulmonary exacerbations. These patients are homozygous for Delta F508. And I will say clinically, when this medication rolled out, we knew in clinical trials that it was studied in patients with an FEV1 that was greater than 40%. And our patients that had FEV1s less than 40% really struggled to take this medication. It caused a lot of chest tightness and shortness of breath. Drug interactions were also a big deal for our patients, including oral contraceptives for our female patients. In the younger populations, they seem to tolerate it better, in my experience. They saw in those 1 to 11 years old that they had decreased sweat chloride again, and that we knew that patients tolerated this drug really well. I have to be honest, I feel like the 1 and 2 year olds that I have on this medication do a great job taking it. Their only complaint is that they say it tastes bad sometimes. Tezacaftor ivacaftor was the third agent to the market, and again, it's a corrector and a potentiator that's approved down to 6 years of age. We were excited about this one when it first came out in adults because it was so much better tolerated than the lumacaftor ivacaftor was in our patients. Again, we saw improvement in FEV1. Our patients really felt like they had a decrease in pulmonary exacerbations, which is what we saw in clinical trials. And then again, they had improvements in their quality of life that were seen. Again, as I mentioned, patients just seemed to tolerate this well, and we didn't have to worry about all the drug interactions that we saw with lumacaftor. And then finally, the new kid on the block who's been around for a while now, we have elexacaftor, tezacaftor, ivacaftor. And this year, it was FDA approved down to age 2. And again, I'm excited to see that we have so many patients starting on therapy earlier on in their life. In adults, we saw significant improvements of FEV1, up to 14 to 15% in some patients. In addition, 60% decrease in pulmonary exacerbations. I have to be honest, for our patients that are on this, we almost never see them admitted to the hospital anymore. We used to have 5 to 10 patients in the hospital at all times, and since starting this, we may have 1 or 2 a month. So it really has been life-changing for them. In the 6 to 11-year-old patient population, again, they had improved FEV1s and improved quality of life. And in the kiddos of 2 to 5 years of age, good safety profile. And what I just want to comment about some of these younger patients that are on therapy, it's always important to check their weight at clinic visits because the doses do change as the kids continue to grow. So there are some pearls that we can use across the board for these medications. For all of them, it's recommended that they have their liver function tests every 3 months for the first year and then yearly. And if you notice abnormalities, I always say just go back to the package insert because they're all a little bit different between all of them. In our kids, because of the risk of cataracts that we're seeing in animal studies, we recommend baseline and then yearly eye exams for our patients. And then again, we still have to think about drug interactions, even with ETI therapy. The biggest ones I think about are probably in our transplant patients who are on things like tacrolimus, and then also our patients that are on chronic antifungal therapy where we have to modify the ETI dose. From a side effect perspective, I listed a couple here that we've seen the most and what was reported in clinical trials: headache, rash, nausea, and constipation. For rash, we've kind of done a couple different things. We have some patients that want to push through with the rash, and then it will resolve with time. And we've had some patients that the rash really bothers them, and we will stop therapy, hold the ETI until the rash resolves, and then slowly titrate up therapy. And they seem to tolerate it better. I know it's not a side effect, But it did surprise all of us when this medication first came out, and it was all of our Trikafta babies, right? We had all these women in our clinics who weren't on birth control, who couldn't get pregnant, and then all of a sudden, I know we had 3 or 4 with very poor lung function that got pregnant. And so I very much encourage all of our patients, if they're not thinking about getting pregnant, to make sure that they're on some sort of birth control going forward while on this therapy. And then regarding dosing, it should be taken with a high-fat meal. We recommend 8 to 10 grams of fat in our clinic. And then for the kids, it's important to remind the parents that the granules really should be used within 1 hour of opening. The Trikafta granules, if you haven't seen them, are a little bit bigger than the Orkambi granules, and they look like little marshmallows, is what I tell patients. I have one mom who even told me she was going to try to stuff them into a big marshmallow just to see if her kid would take it. No hot food, so you want cold or warm food when you're giving it. And if you have a bottle-fed infant, you don't want to put the granules in the bottle. You actually want to figure out how to pull it up in a syringe and give it to the infant that way. So how do we choose? There's a couple different things we can look at. The websites for the drugs are very helpful. You can type in what your patient's genotypes are, and it'll tell you if it's FDA approved in the United States for that indication or not. But I also like the CFTR2 website. And if you haven't been here, it's really a great resource. You can go in, type in your patient's mutations, and not only will it tell you if they qualify for a CFTR modulator, but it will tell you phenotypically what you could potentially expect from the modulator or the mutations that they actually have. So do you think they'll be pancreatic sufficient or insufficient? What is it shown in clinical trials regarding weight gain with people with these mutations? A lot of helpful things that I find patients really like as well that you could show them. Age is important, right? Especially since we have these modulators down to 4 months of therapy now. So I would say most of our patients, at least, are starting Orkambi at 1 if they're homozygous for the Delta F508. And then when they hit 2, we're switching them over to Trikafta. And so we always want to be looking at what is the age and how much do our patients weigh as we continue to modify doses. Also, I kind of think about patient preference and adverse effects very similarly because most patients want to stay on ETI unless there's just something about it that they don't tolerate. So for example, we have an adult patient who just reported significant dizziness with ETI therapy. And no matter what we did, even modifying the dose, the dizziness did not go away. And he had stable lung function, and so he chose to go back to tezacaftor, ivacaftor, at least for now, to be able to work his job and feel like he was more productive within his life. We've also had a couple transplant patients who have reported, and I don't know if this is with the interaction with tacrolimus or not, but significant tremors while on both therapies. And so we've back off to Tez-Iva for both of those patients as well. So we talked about the offense, right? We have our CFTR modulators, but what about defense? We have a lot of defense, and this is what we primarily did before the advent of these modulators. Again, airway clearance is so important for all of our patients, but we also have mucolytics, anti-inflammatory agents, inhaled antibiotics, and bronchodilators. And I'm going to talk about the recommendations that are out there. These recommendations were published in 2013 for patients 6 and up, and they're also on the CF website. So bronchodilators, the recommendations that are out there is that there's insufficient evidence to recommend for or against chronic use of beta-2 agonists or anticholinergics. What I would say in clinical practice is we use them prior to our inhaled therapies, during exacerbations, in those patients that have airway hyperresponsiveness. I'd be interested later to hear what your clinics do, but we do not use the anticholinergics in our center because we have a fear of it drying up secretions even further that may complicate the airways. We also have our mucolytics. Dornase alpha works to break up and thin the mucus in the airways, and it has been shown to not only reduce the risk of exacerbations, but also improve lung function. And it has evidence to use it throughout the spectrum of disease. And it has patient safety data down to kids as young as 3 months of age. Most of our patients do Dornase alpha once a day, although we do have a handful of patients. Again, this was probably pre-ETI therapy that had copious amounts of secretions, and we would use it twice a day in those patients if we could get insurance to pay for it. Biggest side effect we see is probably voice alteration, and that usually resolves with time. For hypertonic saline, we know it increases the hydration of the airway surface liquid in the airways, or potentially it does. I like to tell patients it just makes them cough. We want them to cough and get that sputum up and out of the airways. Generally, in my experience, it's not tolerated as well as Dornase alpha is, especially in our patients that have some sort of underlying inflammation like CF-related asthma or something similar. We know that if they don't tolerate 7%, that they may tolerate 3%. And this can range from being used daily to up to 3 times a day for some of our patients that are hospitalized. Inhaled antibiotics are also important in our patients. And it's become a challenge lately because a lot of our patients are not coughing up sputum to actually know what they're growing down in the airways. We have 2 FDA-approved therapies for patients that have Pseudomonas chronically in their airways. It's inhaled tobramycin and inhaled aztreonam. Inhaled tobramycin, again, is recommended across the spectrum for our patients that have chronic Pseudomonas. Most of our patients will do the solution that they nebulize, and there's several different brands in addition to generics. But a lot of our adults especially like the Toby inhalation powder. I would just caution if patients, again, have airway hyperresponsiveness or lower lung function, a lot of them cannot tolerate the powder burden that goes along with doing the Podhaler device. It's also hard, I found, to get insurance to want to approve it. But for our very active adults that are fairly healthy, it saves them a lot of time throughout their day. Again, we have aztreonam as well, and I will just comment, it's 3 times a day versus twice a day. It's a little bit quicker of a nebulization, although patients tell me it takes longer to clean, so it kind of balances out between the 2. We're having a hard time getting that one approved too. I'd be interested to see what y'all find out, but I cannot get insurance to want to pay for inhaled aztreonam. And then finally, there are other options, although the data is not as strong. And so you may see patients on inhaled vancomycin, inhaled amikacin, inhaled ceftazidime, depending on what bacteria they commonly grow in their lungs. Oh, wrong way. This is just here for reference. It makes sense when you think about order of therapy in our patients, opening the airways, getting that mucus out, having their airway clearance, and then finally ending with their inhaled antibiotic to go in and try to fight that infection. And so lastly in this area, we're going to talk about chronic azithromycin. And this is recommended in patients that do have chronic pseudomonal infections, and also in some patients that have frequent exacerbations that don't have chronic pseudomonal infections. What I will just say regarding chronic azithromycin, it's thought to potentially work as an anti-inflammatory, also potentially to help antibiotic penetration into biofilms. What I worry about is we see an increase in non-TB mycobacterial infections in our patients, and they can no longer cough up sputum. It concerns us if we should keep on this therapy or not. We know that macrolides are a cornerstone of therapy for NTM, and if these patients become resistant, it can be a big deal. So just food for thought when you have patients on this therapy and when you're thinking about things to start pulling off. We also have defense of the pancreas and the liver. And the one I'm going to focus on today are pancreatic enzymes. We know that about 90% of patients with CF will have pancreatic insufficiency, and they will have to have enzymes supplemented to assist in breaking down fats and gaining weights. Most of us probably have a great dietitian that we work with that does most of this, but just a couple things to know. The dose is usually based on weight or grams of fat. And I feel like we've always been warned about fibrosis colonopathy in our patients. And I'll be honest, these great guys pointed out to me there was a recent study published this month in the Journal of CF that showed this was actually very rare as long as we use current FDA-approved enzymes, and we also use standards of clinical practice for dosing. I do see some retail pharmacies that want to try to switch the brands around, and that is generally not recommended. They have not been shown to be equivalent, so we try to keep our patients on the brands they best tolerate. In our kids, you can open these capsules up and mix it with applesauce. And because they have so many enzymes that get sent to them every single month, it's important to remind your patients to keep them in a cool, dry place so that the enzymes will still be effective when the patients are using them. Okay, so HC is back. Her PFTs look really good. She wants to know if she can stop any of her inhaled therapies. So I want to take a second to talk about the Simplify study because HC isn't alone in her goal to decrease her therapy since starting ETI. We know that decreasing therapies has been found to be very important to our patient population. This study basically looked at adults or 12 years and older and patients that had been stable on ETI for at least 3 months. You can see that they were fairly healthy, with adults having a baseline FEV1 of greater than 60% and kids having a baseline of greater than 70%. Patients could be on either hypertonic or Dornase or both, and they basically got randomized for 6 weeks to either be on hypertonic or off, on Dornase or off, or if they're on both therapies, they could actually be in both sides if they wanted to. And what they actually found, if you look here on the left-hand side, is that stopping therapy was non-inferior, and it didn't make a difference in those patients that were fairly healthy. I will say in those adults that had an FEV1 of less than 70%, they did report potentially more coughing when they were off therapy. So our caveat with our patients has really been, if you're on both, which one do you feel like works better for you? Stop the other one. Let's recheck PFTs. We all have home spirometers in a month or so. And then let's see how you're doing. And then if you feel like you're getting junky or you're getting sick, there's nothing that says you can't go back to using more therapies again. And our patients have loved this. And it's made them not only happy having more time back in their day, but it's also helped them to feel confident in decreasing some of their therapies. So HC stopped her hypertonic because she felt like she tolerated Dornase better. But she comes back to clinic 6 months later, and she notices increasing anxiety and weight gain. She attributes this to her ETI therapy. She said she's exercising, she's eating healthy, and she wants to know if we have any suggestions for her. So this was just published as well, and I think it's a good review of some of the stuff that's in the literature, but also mechanistically what we think may be going on with ETI therapies and the side effects we're seeing. I keep going the wrong way. Sorry about that, guys. What they found is that even though in clinical trials, headache was the only neuropsychiatric side effect that was seen, in real life, we're seeing worsening mood, cognition, anxiety, sleep, and even suicidal thoughts in some of our patients. And the European Medicines Agency is actually, if they haven't already, getting ready to add depression to the warning label for their Kaftrio. There's several different mechanisms here, and I find them very interesting. And again, I would refer you to this paper if you want to dig deeper into what they think the reasoning may be behind this. This isn't all the case series that are out there, but these are a couple that I just wanted to briefly talk about. The first was by McKenzie et al. In 2017, and it was a case series that had 5 adolescent females on lumacaftor ivacaftor. And after they started taking this therapy, these 5 females all reported worsening depression, 3 had suicide attempts, 2 had ideation, and they all ended up stopping therapy. Once they stopped therapy, 3 were improved, 1 had no change, and 1 was lost to follow-up. Heo and colleagues in 2022 reported 6 patients on ETI therapy, and of those, all of them reported increased fogginess, 5 reported word-finding difficulties, and it was so significant that 2 ended up stopping therapy with ETI. 4 continued full dose, but not all of the symptoms resolved in all of the patients. Spolatini in 2022 did a chart review of 266 patients on ETI. And I'm going to talk about how they reduced dose on the next slide. But what's important to note in these patients is that 19 reported anxiety, low mood, brain fog, and trouble sleeping. And they actually dose reduced in 13 of those patients, and 10 reported improvement. And then finally, it was published this month, Barut and colleagues did a chart review of 148 of their patients on ETI. 31 of those patients were seen by a CF psychiatrist. Of those 31 patients, 16 reported increased neuropsychiatric symptoms that they did not believe was prior to ETI. Because of that, 2 ended up DCing therapy, 9 had a dose reduction, and 1 patient ended up flipping the AM and PM doses with some benefit. So how do we adjust, right? This is the conundrum we all have in clinic every single day. The Spolatini article I thought was very interesting. They basically use sweat chloride and markers of patient stability to determine the safest and best tolerated dose of ETI in their patients. In their study, 13 of their patients underwent a dose reduction, and all of them had sweat chloride stay within the normal or borderline values. And for those patients, 10 of the 13 again did report improvement in the side effects. In our clinic, we use our home spirometers a lot. For our patients that report mood changes, a lot of the times we'll start with twice weekly full dose, sometimes 3 times a week, and we'll have patients monitor symptoms and home spirometry to see how they do. A lot of our patients do great, continue to have good lung function. I would say our patients that have poorer lung function, they don't do as well, and we've had to go back up to full dose ETI therapy in most of those patients. And so that leads us to treating the neuropsychiatric symptoms. A lot of us recommend psychotherapy. We treat them with SSRIs or SNRIs. And the paper by Barut et al. Actually used stimulants to help with some of the mental fogginess that their patients saw. So HC is back. She's doing great on her modified dose of 3 times a week, Trikafta. Her weight gain has remained stable. She continues to check her home spirometry just to feel confident that her PFTs are good. And she's also started psychotherapy to exist with our anxiety. So I think it's important for us as pharmacists to just remember that there's a lot we don't know, but there's also a lot we can do. In this day and age, I think we're able to monitor our patients closer than ever before, again, especially with all the home spirometers that went out post-COVID. And it's also important for us to rely on each other. And so some of the coaches that I want to talk about within this presentation are, if you don't use a lot of these things, the clinical care guidelines on the CFF website are excellent in helping us to manage our patients. There's a great review article about the indispensable role of pharmacy services in medication management that's published that I would refer you to. And then again, like I said, I think we have a fantastic group of pharmacists and technicians that really care about our CF patients, and our listserv is very active. And I know that I get a lot of very, very helpful suggestions on what to do with my patients from what all of you guys post on the listserv. And with that, I just want to say thank you.
Thank you, Wendy. All right, next up to the plate. Dr. Stacy Peters is a clinical pharmacist with Sanford Children's Specialty Clinic and professor of pharmacy practice at South Dakota State University. Stacy Peters received her Doctor of Pharmacy from South Dakota State University in 2004, followed by a 1-year pharmacy practice residency at Sanford USD Medical Center. During this time, she became involved with the South Dakota Cystic Fibrosis Center in Sioux Falls, South Dakota. In 2005, she accepted a joint position between Sanford USD Medical Center and Sanford Children's Specialty Clinic. Her focus was developing a CF clinical research program, which led to the center becoming accredited as a TDN center in 2009. In 2007, she accepted a position with the South Dakota State University College of Pharmacy and Allied Health Professions, which is a joint position. In addition to outpatient and inpatient care, Dr. Peters plays an instrumental role overseeing research at the South Dakota CF Center. She has served on the CFF TDN Protocol Review Committee and the CFF CFTR Guideline Development Committee. Dr. Peters is actively involved with the CF Foundation and speaks at numerous community and healthcare venues in the field of CF. Additionally, she is the vice president and co-founder of Breathe Bravely, which connects patients with CF to professional vocalists to promote well-being through the act of singing. She has not volunteered for a concert tonight, though.
No, I don't sing. I just connect them to the vocalists. No, my vocal abilities are very limited. All right, so, and this is my 20th CF conference. So there's a few of us that are veterans in here. But yeah, so I've been doing this a little while. And just a few things. At our care center, we have 170 patients total between our adults and peds program. Just to give a reference of our patient load, and I only have 5 patients that are not eligible for CFTR modulators based on mutations out of that 170. So just to give you an idea, my inpatient load is this big. So, which is fine because I wasn't ever, technically I'm not an dedicated inpatient pharmacist. I am on the clinic side, but I do all of our CF inpatient stuff basically. All righty. Oops. There we go. I don't have anything to disclose. And today we're going to be looking at the principles of antibiotic selection and dosing, propose strategies for effective formulary management, and develop successful transition of care models for complex patients. And this is a big scope, so obviously this is going to be very high level information, hopefully just to get you guys thinking about some things. Definitely not going to be diving into the details, but hopefully this will give you some food for thought as you're going back to your practice sites or developing your care practice model at your center. So with antibiotics, we'll talk about selection, PK, monitoring, duration of therapy, some principles of antibiotic dosing, mainly just antibiotic regimens for Pseudomonas and MRSA, because we don't have time to go into all the others, and then aminoglycoside dosing and monitoring. So I'm just going to put this up here. This is from the 2009 CF exacerbation guidelines. So obviously, they're a few years old. And I just want to point out a few things from this set of guidelines that I think is still worth noting. One thing is for recommended therapies, they do recommend that we continue those chronic therapies on the inpatient side. In terms of inhaled antibiotics, they found insufficient evidence to recommend for or against inhaled antibiotics in combination with IV antibiotics on the inpatient side. And we'll sort of touch on that as well. They recommend continuing your airway clearance therapies. And on what we do is we tend to go to 4 times daily dosing with all of our inhaled therapies and vest therapies or whatever their airway clearance technique is. Number of antibiotics to treat Pseudomonas. At the time of this, there was really no data to suggest that we would go away from dual coverage for Pseudomonas. There is a study that's underway, Stop 360, that maybe will give us a little more insight to that. And then aminoglycoside dosing. At the time of this review, they gave it a level C it was a small level or small magnitude of benefit. I still feel like now if we were maybe to revisit that, I feel like there's a lot more publications out there now. Maybe we would move the needle on that one. And then for continuous infusion beta-lactams, they had insufficient evidence at that time. I guess at my practice site, we're not utilizing continuous infusion as much as we used to, partly just by sheer numbers of patients, but also because of some of the newer antibiotics that we have that we can utilize in some of these more difficult to treat cases. And then duration of antibiotics, I'm going to save for one of these upcoming slides because there is some new data out on that. And then synergy testing, we've, gone away. I'm trying to remember. A lot of us probably don't even remember synergy testing being done, but we did that in the beginning. We'd send off our Pseudomonas samples and get this pretty little chart back. I just loved it. And then systemic steroids, insufficient evidence to recommend for or against systemic steroids at this time. So one thing I want to touch on is the duration of therapy. And there was recently, recent as in 2021, study, the Stop 2 study came out. And basically the takeaway is that we probably don't need to do these prolonged IV courses like maybe we did years back. Our standard at Sanford used to be we pretty much did 2 weeks on anybody who got admitted in the peds world, and most of our adults ended up on 3 weeks. And now that practice has definitely changed. And I feel good, like after sort of seeing the STOP study data, that for patients that tend to be early responders to therapy, you can probably go with that 10-day course. But for those that are, later responders, or maybe they're not responders, doing even just 14 days versus 21 days is sufficient. So that's been a change that we've definitely embraced, is cutting back on the duration of antibiotics. And I would encourage you to look at this study. Some things to keep in mind as we're thinking about treating, just consider your site of infection. Obviously, we have bacteria present in the tissue, in the airway surface liquid, in the sputum. And so I like to just think, okay, where am I trying to get my antibiotic to, and how good is there going to be, penetration of that antibiotic to where I'm trying to get it to. And so I keep that in mind as when I'm thinking of the rationale for our higher doses that we use in CF, along with they have increased faster clearance of certain antibiotics. And then type of bacteria. We know that Pseudomonas develops resistance rapidly. It also has its little protective biofilm that makes it more difficult to treat. And so keeping that in mind when you're selecting those antibiotics that maybe have better biofilm penetration. The CF microbiome could be a whole nother topic, but we know that what we see on a culture isn't necessarily representative of everything that's in the CF airway. So keeping that in mind as well. I read a study years ago that said that the average adult CF patient has 50 different identifiable strains of Pseudomonas in the airway. That sort of freaks me out, because I'm always we're looking at this culture data and here's what we're going to do based on that. Well, maybe it doesn't even matter. But so just keeping in mind that we obviously have this very diverse microbiome in the CF airway. And then we use our culture data, obviously, to guide our therapy. And so looking back, seeing what their most recent culture looked like in terms of a susceptibility pattern. And then also, do they have coexisting bacteria that we're trying to cover when we're deciding on which antibiotics to select. Oops. There we go. Okay, so I'm not going to cover the detailed dosing of everything because it would take forever, but I really want to tell you to go pull the studies that were wonderfully done by some great pharmacists. That the series is called The Optimization of Anti-Pseudo Antibiotics for Cystic Fibrosis, and they have, each publication focuses on a class of antibiotics, as well as there's a summary one. And they really go into great detail on what data they utilize to sort of come up with the recommendations. And so this series of publications is what I utilized to justify what dosing I put into my antibiotic admission orders and things like that. So that's what I present to our committee that approves admission orders to justify why I selected such and such dosing. Because we don't have just a outright guideline, and this is about as close as we get to a guideline as this series. In general, what I'm going to say is that we use higher doses than what the FDA recommends in many of the scenarios with antibiotics. We use extended infusions. We can use continuous infusion, and just keeping in mind that we are treating difficult to treat bacteria in a difficult location to reach in patients that have increased clearance of certain antibiotics. And so I'm not going to go through these, but I just want to share them with you so that you have them to refer to. There is a guideline for the carbapenem dosing. You can notice just right there with the aztreonam max dose of 12 grams a day, which is much higher than our typical FDA-approved aztreonam dosing. Our quinolones, specifically Cipro, we utilize that higher dosing than what's FDA approved. And then I do want to just spend a couple seconds on colistin. We don't utilize colistin as much as we used to, just because people aren't getting admitted like they used to. Colistin for me is sort of my replacement for tobramycin if I have a patient that's had vestibular toxicity or has hearing loss. And so this is sort of my backup to tobramycin when I'm trying to still get dual coverage with really opposing mechanisms of action. And what I do want to point out for those of you that aren't familiar with colistin dosing is that there's different ways that the dosing is reported in the literature. It depends on whether you're looking at colistin base activity versus colistin sodium. And so just be very cautious when you're coming up with your recommendations for dosing, as well as when you're reading literature, paying attention to how the doses are being reported. The other thing is I would check with what your EMR default setting is and base your guidelines off of what your EMR automatically is going to default to. So at Sanford, we have EPIC. We use colistin-based activity as our dosing regimen. The other thing I would say about colistin is it would be helpful to have a guidance document for your inpatient pharmacist to utilize. We have a handoff sheet. We're still sort of like, I still love printing stuff off. I can't help it. But so we have a guideline monitoring sheet where we have the initial dosing and rules for escalating the dose. So the incidence of neurotoxicity is very high with this medication, and so you really have to be doing a frequent assessment on the patient, and it's dose related. So as you go up with that dose, you are going to see a higher prevalence of those adverse effects. So we have our initiating dose, we have our max dose, we have our creatinine, and then we have, did you ask the patient about your neurotoxic symptoms? For me, the first thing that they report is we call it battery tongue. Anybody else call it battery tongue? Like, feels like you're putting your tongue on the end of a 9-volt battery. And my students look at me like, well, why would you do that? And I'm like, well, that's how you knew if it was charged or not. Like, I don't know. So that's typically the first thing my patients tell me is that, oh, I got the battery tongue going on. I'm like, okay. So now you learned something new today. All can go home and put your tongue on a battery. All right. And then our aminoglycoside dosing. So I don't think I've ever used gentamicin in CF, so we don't need to worry about that one. And then we have our amikacin and tobramycin, and we do high dose once daily dosing with both amikacin and tobramycin. The one thing I really want to emphasize right here is the amikacin dosing listed here is for Pseudomonas. It doesn't apply to Mycobacterium. So just realize that there's different dosing for Mycobacterium infections than what you see here. For tobramycin dosing, or if your institution utilizes more amikacin dosing, whichever your drug du jour is. I don't like it when I can see David raising his eyebrows. So I would just recommend that you have a standard approach to your aminoglycoside dosing. Develop your monitoring sheet or guideline. Develop an EMR template for documentation so that you have a easy-to-go progress note built into your system. What we utilize at our institution and this is pulled directly from the optimization series, is empiric dosing of 10 mg per kg, unless they've needed higher doses in the past, and we'll go with the historical dose that they were last on. Higher doses are very often needed, especially in the younger, skinnier kiddos. We use a target CP max of 20 to 40. I might adjust that under unique circumstances, like for a patient with some hearing loss that we're nervous about using it in and they have a susceptible Pseudomonas. I might say, hey, let's just aim for 20 to 30, just sort of come to the lower end of that. For AUC, we utilize 80 to 125, and I think that's consistent with the optimization series as well. And then I have my PK equation set up for post-dose levels instead of like pre-dose, post-dose levels, which sometimes some of our pharmacists still utilize pre and post-dose aminoglycoside levels. And then when you're looking at the timing of levels, I go with 1 to 2 hours after the end of the infusion. So on the inpatient setting, I typically will order that level for that 2-hour mark because I worry that the dose is going to be given late, phlebotomy maybe shows up early, what have you. And so that gives me just a little extra wiggle room of avoiding that distribution phase. And then typically about 6 to 8 hours post-dose is when I'll get that second level drawn. You don't want to draw it too late because that level might not be measurable, or you might clip that redistribution phase, and then that can sort of skew your results in terms of like your half-life and calculated CP max. So making sure you're capturing those levels during that linear elimination phase is just critical. We try to do AM dosing if possible for a few reasons. One, there's some potentially reduced nephrotoxicity with this. And then also because if they're going to go home, I want it to be on a work-friendly schedule or just a practical schedule, since they'll have to go in and have labs drawn during like that 8 to 5 time period. And then monitoring for ototoxicity and vestibular toxicity. I always counsel my patients on admission, reminding them of these adverse effects. We do periodic audiology. We used to just sort of do it once a year, but now it's just sort of, there's not really a standard because we don't have patients coming in anymore. But I also counsel them on what those symptoms of vestibular toxicity could feel like. Like, it's not just dizziness, it's room spins. It's not being lightheaded, it's that room spins when you've had a few too many. And then the hearing loss and the ringing in the ears. Also, I just want to comment, in case you're new to the CF world, that toxicity can show up even several weeks after stopping tobramycin. And then also, if they develop hearing loss, that hearing loss can still progress too, even after stopping. So it's really important that we make sure that they can identify that early. Okay. So sort of to summarize, with the Pseudomonas, obviously we're going to be getting those 2 antibiotics from different mechanisms of action, keeping in mind what your concurrent bacteria are, and using aggressive dosing. With MRSA, again, I feel like this is a little bit more normal on our day-to-day, so I'm not going to go into too much detail here. In terms of selecting, I think you're really going to look at the practicality side of things. Are you inpatient? Do you have them also on tobramycin? So like if I'm sending somebody home and they're already on tobramycin, I don't necessarily like to send them home with Vanco 2 because it just gets to be some wonky schedules, as well as I have limited ability to maybe get their lab monitoring when they're at home. Obviously the susceptibility, previous tolerance, are you going to use ceftaroline when you've got them on cefepime, for Pseudomonas? Those types of things is sort of what I think about. Just note again that there's higher doses for many of these antibiotics, so be sure, and this goes to the clinic side too, having some dosing charts made up for your practitioners with appropriate dosing is a very good thing to do, to just sort of encourage them to use the correct dosing. I'm just going to mention the AUC goal with vancomycin, greater than AUC to MIC ratio of greater than 400, trough typically 15 to 20. We did a survey many years ago, and at the time, very few people were doing AUC monitoring. I would be very curious to see now if we've had a complete flip. So I feel like that's pretty straightforward for those of you who are pharmacists. So moving on to antimicrobial stewardship. I'm not going to lie, I have a hard time with some antimicrobial stewardship because I feel like my brain is so used to, throwing everything at this, the patient when they come to the door. So sort of some things that are easy to adjust would be, having some restricted use on antibiotics, so that people just don't automatically prescribe meropenem because the person walked through the door, or prescribing ceftolozane tazobactam because they walked through the door. So trying to reserve those that we need to save when we really need them. Broad versus narrow spectrum, this one I'm struggling with a bit too. So when do you step down? And so say you have this patient, they've maybe had some Pseudomonas and some staph in the past. So you start them on tobramycin and cefepime, and then their culture comes back just staph. So then you drop that tobramycin, but some may argue you maybe should step down your cefepime too to Ancef or something like that. And that's the piece that I struggle with, is just trusting that there's not Pseudomonas there. But I mean, if we were really being good stewards, we'd want to narrow that spectrum up even further. And then number of antibiotics, we still don't have literature to say that we can't do double coverage. So I'm still doing double coverage on my patients. Duration of therapy, the one nice thing is now we can feel like we can get by with these shorter durations of therapy, which also should help with our potential for developing resistance. Oops, did I miss one? I don't think so. Okay, just a few things to think about. How long do we cover for Pseudomonas? I don't know. Use of inhaled antibiotics inpatient, we really don't have evidence to do it. We do it at our institution, but that doesn't mean you need to, and it may be a way to limit your formulary. Do your providers feel like you should use what is your view of the inhaled antibiotic? Is it considered a second drug for dual coverage, or is it another add-on? And we don't look at it as a second drug for dual coverage on the inpatient side. It's more of an add-on. And then do you continue azithromycin if they're on IV or inhaled tobramycin? We try to stop it on admission because of the antagonism between azithromycin and tobramycin, but I'll be honest, we don't always get it caught. I guess I should add that to my admission order. For formulary management, big thing here is you don't need to carry everything. Have a handful of enzymes that you stock. We don't stock many, but we also have a very low inpatient load. But we have enough that we can, okay, well, maybe we don't have the 36s, but we have 24, so we can usually get to that dose okay. We only carry one brand of vitamin, and so we try to limit some of those extras that we have in our pharmacy. And then also just know what your institution's process is for formulary requests. For other sort of formulary management things, like we just carry one form of inhaled tobramycin. So whatever the cheapest option is what I say, okay, great. If you do carry aztreonam for inhalation, you want to have an SOP in place for disinfecting that Altera nebulizing base unit. And then other things to think about is what is your hospital's current antibiotic formulary, and is there anything missing that you really feel like you need to put in there? And do you have clistamethate on it or not? Do you want it? Those are just some things to think through. The other thing I would just say is be friends with your people who are your contacts. Phone calls go a long way just to help facilitating a process for getting a medication. For modulators, your options are maybe add to formulary, non-formulary, patient home supply. We do patient home supply, but we already have gone through the process of what we need to do to order it, and we can get it within like 1 or 2 days. Relizorb, where you're going to order it from. It can be drop ship. It's drop shipped directly from the manufacturer. We go through Cardinal. But then the other bigger decision with that is who's going to carry it and dispense it. Is it going to be from one of your central supply departments, or is it going to be coming from pharmacy? We use pharmacy. And then with that, I would say making sure you have dosing instructions and MAR details set up to be complete with Relizorb. 340B pricing, basically, this is going to be a significant cost savings compared to wholesale acquisition costs, somewhere around that $5,000 to $7,000 a month, basically in that range per fill. So the savings from 340B pricing can be used to expand health services at institutions, which can include adding pharmacists to clinic and helping offset that salary compensation. This is mainly just for outpatient prescriptions, though there's some weird little caveats out there. I would just say know who your 340B person is, and also, obviously, us listserv people can try to provide you insight. Sort of along those same lines of formulary management, just be actively involved in your admission order development. If you haven't looked at your admission orders, take a look at them and see where you want to either streamline things, only list the products that you actually carry or want them to be utilizing, and having options for pharmacy to adjust or dose, things like that, as well as okay to take home meds on those things that you want to just be automatically done on admission. Transition of care, clinic to inpatient. So when we're admitting a patient, typically I pick up the phone, call the decentralized pharmacist, and then I also put in an intervention, which is in Epic. But things that I include would be culture data, recent antibiotics, decision-making that we came to, especially if it's a wonky regimen that they might look at and be like, why did they decide that? Initial dosing, anticipated duration therapy, and whether or not home infusion is going to be on the menu. I also give them a heads up if they're bringing their CFTR modulator in with them, and I usually tell the pharmacist, just go to the room and identify it, because I just never like it to really leave the possession of the patient. Enzymes, I'll give them a heads up on enzymes, and then usually my next phone call is to central pharmacy and be like, hey, this is the enzyme this patient's going to be on. How many bottles do we have on the shelf? You might want to order more. Or if we don't have it, hey, can we get this shipped by the next day or two? And then we have a little bit of, I think I'm spoiled when I hear other people's concerns, because I can order pretty much anything if I want it. So while we might have their Pertzy on hand, I'll have it within 1 to 2 days. Otherwise, if they don't care, then they're going to stick with our Creon XYZ dose that week stock. And then the other good thing is to notify the research team if they're in a research study so that SAE reporting process can get started. And then there also is that part, like, is this anything potentially related to a medication that we need to make a determination of whether or not that research drug needs to be held. For inpatient to home, a lot of communication with home infusion. For the most part, it's a pretty standard process, but say you're utilizing maybe a newer medication, check with them and making sure that it's stable, or what you're going to be what they're going to be going home with. Does it need a pump? Things like that. Antibiotic. I also ask about insurance, infusion duration times. I try to always get those, another set of levels right before discharge so that we reduce that, coming into lab. And who's going to monitor those levels? Is it going to be you? Is it going to be the home infusion place? Is it the inpatient pharmacist, the clinic pharmacist? I do my own. So for me, I communicate with home infusion, like, here's the day I'm going to get the levels, but they're getting it done in Faith, South Dakota. So it's an hour to the lab, and then it's going to be transitioned to Mayo or Sanford, and then it's going to be 3 more days before I actually get that level back. So you need to make enough doses to go through this date. Oh, and there's a blizzard, so let's make this many more doses. So really try to just think of the practicalities. And then if it is going to be managed by home infusion, then I give them the PK targets. But definitely just always keeping that communication open. Inpatient to home with therapy completed, just making sure any medications that need to be reinitiated at discharge, obviously. Ensure your patient has been educated on any newly initiated meds while they were in. And then this one for me is a big one, like, they're trapped in the hospital, and now I can make them fill out all the paperwork that I've been trying to get them to do. And we get on the phone with HealthWell, we get on the phone with the specialty pharmacies, we take care of all that stuff while they're inpatient and make sure that they get their stuff done. All right. So that was a little fast, but I think we have a short little break.
Yes.
And
so right now will be our halftime. So we'll have 5 minutes for Q&A, or if you need to take a quick break. So we encourage you guys to either enter questions into the app or step up to the plate and ask your questions to the microphone. So we'll ask Dr. Bullington also to come up and so you can direct questions to them. And I guess while we are waiting for questions to come in, this first question will be for Dr. Bullington. So you mentioned the Simplify trial and being able to safely discontinue mucolytic therapies in relatively healthy people with CF. What is your approach for discontinuing other medications like inhaled antibiotics if they haven't grown Pseudomonas in quite some time, or say like chronic azithromycin?
So we like to stop inhaled antibiotics in our center if they have not grown that bacteria in a year. Still, I go back and forth, still makes me a little bit nervous because we don't really know what's down there in the airway because we don't have sputum production. But most of our patients, if cultures are clear for a year, if it doesn't grow on swab, we stop our inhaled Toby in our patients. Azithromycin, I feel like that's one we're not stopping as frequently just because patients don't seem to mind it as much because it's oral compared to being inhaled. We have been stopping it in patients that are generally stable, high lung function, and if they start having frequent exacerbations, then we generally will go and add that one back. But I think about the NTM as well a lot, and so it is something that we discuss when we pre-round for our clinic patients about whether or not we should keep those patients on oral azithromycin.
Great, thank you. And I guess also we can poll the audience, what else are you all doing? Because I think that's a huge question for everybody.
Hey, Michelle Condren from Tulsa. We're more likely just not starting it. So like when they turn 6, if they don't have Pseudomonas, now that we have Trikafta, we're kind of just waiting to see unless maybe they have asthma. And then we've had some people who've grown into a higher dose and we're like, well, maybe this is a good time to talk about maybe coming off of it. I don't think we've had anybody who's stable, older, that we've said, let's just try stopping this. Unless they're just not taking it, which has happened too.
Yeah.
Afternoon, everybody. I'm Johnny Grant from Johns Hopkins. Nice to see some familiar faces. We have been doing, for azithromycin, we've been doing a QI project. If their lung function is above 70%, they've been on Trikafta for like at least a year, and they're doing well and they're stable, then we've been stopping it, and it's been working well. And then we would restart if they've had increased exacerbations, but it's been going well to take them off.
That's great. And maybe next year, submit a poster so we can all learn about what you guys find out. That's awesome.
Any other questions before we move into part 2, our second half? No?
You guys have to laugh more at our puns. We worked really hard on these. We were going to bring little foam fingers too, but we thought that might cross the professionalism part. All right. Next up, we have Dr. Taylor Imburgia. She currently serves as the pediatric clinical pharmacy specialist for cystic fibrosis and pulmonology at the Johns Hopkins Hospital. Dr. Imburgia earned her Doctor of Pharmacy degree from Northeastern University in 2019. She completed a general PGY1 practice residency at the University of Wisconsin Health, followed by a specialized PGY2 pediatric pharmacy residency at Riley Hospital for Children's at Indiana University Health. Prior to her role at Johns Hopkins, she worked as the clinical pharmacy specialist for both pediatric and adult patients with CF at West Virginia University Medicine. Her clinical research interests include cystic fibrosis, infectious disease, medication access, and pharmacy education.
Thank you so much for that introduction, and thank you for the opportunity to speak today. I'm a little bit earlier in my career than some of my speakers that we heard from earlier, and so I feel really honored and blessed to have all of your collaboration and mentorship thus far in my career. Today, I will be hoping to shed some light on how we can maximize the role of the CF pharmacist in the post-modulator era. I have nothing to disclose. And today, my objectives will be to first outline the traditional and then novel roles of the CF pharmacist. We'll talk about some of the extra clinical opportunities that exist, and we'll also discuss how you can construct metrics in order to both justify initially as well as sustain your pharmacy services. So even outside this room, teamwork is what makes the dream work. So we know that our CF patients are cared for by a variety of providers, and the Cystic Fibrosis Foundation has classified certain care members as either required or recommended in order to meet accreditation standards. So in 2015, pharmacists were added as a recommended team member, in addition to some of these other allied health professionals that you see. Prior to adding pharmacists as a recommended team member, there wasn't a lot of guidance on what pharmacists could be doing in clinic or what they should be doing, at least in the United States. So other international CF organizations, such as the European Consensus, the United Kingdom CF Trust, and CF Australia, recognize pharmacists as core team members and have specific duties that they should be fulfilling in their guidelines. However, this did not exist in the United States, and so there were surveys that were conducted of both pharmacists in CF care centers as well as directors of CF care centers to ask what these pharmacists were doing in the clinic. And so as you look at these tasks, I think it resonates with the pharmacists in the room that this is our primary goal for a lot of our patients. So of course, we want to make sure that they're on safe and appropriate and cost-effective medication. We want to get an accurate medication history, and that comes through building rapport and trust. We want to educate our patients on any of medications that we're starting, especially CFTR modulators that need to be taken in a certain way and have various side effects that we may need to monitor for. We help our clinical team select drugs and answer any off-the-wall questions they bring us. And then, as previously discussed, pharmacists can attend inpatient rounds and provide PK support for the team. And then in other roles, we also can serve as a liaison between the outpatient primary care team, as well as who's going to be taking care of the patient in the hospital, whether it be the inpatient service or the pharmacists themselves. And then we want to mentor the next generation of pharmacists and precept our pharmacy learners. The impact of pharmacy services has been well documented in the literature, thanks to many in this room. And so, importantly, we see improvements in medication adherence when you add pharmacy services to your team, whether that be medication possession ratio for drugs like Dornase alpha or for inhaled tobramycin. We also have seen associations with adding pharmacy services to improvement in clinical outcomes, such as weight or BMI, rates of hospitalizations or ER visits, or other lab values such as vitamin D levels. We're able to improve medication access by reducing time to prior authorization approval, the time to delivery of medications when we use health system specialty pharmacies. We can also help our patients utilize all the resources that they qualify for in order to make their medications more accessible and affordable. There's also been documented improvements in vaccination rates, and it's been shown that patients are more likely to discuss their medications with other members of the CF team if there's a pharmacist that they're meeting with in clinic. Other great improvements that we've seen are reductions in medication errors, so making sure patients are getting the safest therapy possible, as well as reductions in medication costs, not only for the patient, but also for the health system. So if you're able to optimize therapy earlier on, if they're able to discharge earlier because they improve, you can overall reduce your healthcare costs and your medication cost. The typical pharmacist role in CF clinic first begins with a preclinical review. So most of us will review if a patient is eligible for a CFTR modulator and ensure that they're on the correct dose. Especially as someone who practices primarily in pediatrics, we very closely look at our dosing. We know as patients grow and as they get older, they're going to need more frequent dose adjustments. We screen for drug interactions, and we also look at their refill history to get a sense of if they may be adherent at home. During visits with patients, we review their allergies and their medicine list. We do adherence assessments, whether it be more formal or just some quick questions, sort of screening their knowledge about the medicines that may give you a hint as to how adherent they are and how knowledgeable they are about their medications. We'll screen for specific barriers that they may be having to adhering to their therapy. We'll provide education on any new therapies that we're starting. We'll also help instill in them medication knowledge and independence as they get older to help prepare them to transition to adult care if they're a pediatric patient. And then we can assist with antimicrobial selection, whether that be in the outpatient or inpatient setting. There are several barriers to adherence that we may see for patients, and it may be as simple as a memory difficulty, knowing that they have to take medications multiple times per day. Maybe after they've worked a complete day and they're exhausted, they just forget about their evening medications. Or maybe they just don't have any sort of system that would trigger their memory and it just gets lost. Those are very common things that we could see. Patients might just not be knowledgeable about when they're supposed to be using their medications or about their regimen or what benefit it's providing them. Cost can be a significant barrier and one that you might have to dig a little deeper in order to identify. Time constraints, so a lot of people say, my schedule's too busy, and if you look at a CF regimen, that is a legitimate concern, and so we do want to try to be mindful of our time and make sure that the therapies we're keeping patients on are ones that they truly need to be healthy. Polypharmacy is something, so more pills that you take, it's just harder to get people to adhere to all of them, and maybe some things that seem less important. For example, vitamins are ones I hear a lot, might fall through the cracks. Drug formulations, I work in peds, certain drugs are yucky, certain pills are too big. So those are things that we have to work through. And then side effects can be a deterrent to adherence, and then just low motivation, which will help us transition to our next slide. So motivational interviewing is a technique that has been shown to potentially improve medication adherence. And there are lots of different resources that you can find to look at motivational interviewing, but really your goal is to have a patient-centered discussion where they're doing most of the talking instead of you saying, you're not doing your therapies and you need to do more of this because if you don't, X, Y, and Z is going to happen to your health. You really want to have a discussion where you figure out how well do they understand their disease. Does their current treatment plan align with what their goals are for their overall health? Are they ready for a change? And then can we help empower them to strengthen their intrinsic motivation, but also just their self-efficacy so that they know that they can make these changes? You want to really start by building great rapport with your patients, trying to stick to the task at hand. I like to ask a lot of open-ended questions and just kind of see where the discussion takes us, and then try to get an agreement at the end of what's this one thing we think we might want to change, and let's reassess next time. And just having a continuous discussion, knowing that the thing that you might think will work well for them just might not, and you may have to try something else the next time. There are various adherence strategies that can be utilized in addition to motivational interviewing. You really do want to provide individualized solutions for patients, so asking them things about their schedule, when they eat, what social support they have can be really helpful to finding the solution that will work best for them. We want to simplify their regimen when possible, so try to limit the amounts of times in the day where they have to take medications. So I've had some patients say, well, I take some medicines at dinner, but then I'm waiting to take my Trikafta until 9 p.m. because it's 12 hours apart, right? And they're so proud that they know what it says on the bottle, but we could be doing something that could make their life easier. So trying to just take those easy wins to help patients simplify their regimen. When insurance allows, decreasing the number of pharmacies can be very helpful for patients so that they can order refills in a more seamless manner. And then using efficient medication formulations, whether that's using an MDI instead of a neb, if it's using a podhaler, or an Altera nebulizer instead of a traditional nebulizer. This can make therapies either more portable or just faster for patients. Incremental goal setting is really important. I think that if a patient is taking no medication and you tell them to take all of them, that's really going to be very daunting. They'll try for a day or two, fail, and then be right back where they started. So I really try to target the highly effective therapies first, and then if they can show good improvement to that, that's when we start incorporating maybe some inhaled medications, the enzymes, the things that are important, and then maybe saving things that are a little bit less important for the end. And then also just knowing if a patient can't comply with something in a way that's going to be safe, especially if we have to worry about antimicrobial resistance, they just may not be a good candidate at that time to use that therapy. So just being mindful and not always sticking straight to the guideline. And then in today's era, we want to leverage technology. So almost all of my pediatric patients come in on a cell phone or a tablet, so let's use it. There are different mobile applications that can not only let you track how well they're doing with their adherence, they can potentially share that data with you, but you can set different push notifications so that patients can be reminded to take their medicines. There are also these fancy smart pill containers. They range in price, but you can find some relatively inexpensive ones as well, and it can help the patient organize their medicines as well as the pill box itself, I've heard, can also make noises and be effective, or it can just come to your phone. In addition to sort of standard outpatient exacerbation treatment with oral antibiotics, the CF pharmacist can have a role in more specialized antimicrobial therapy. So we talked a little bit about OPAT, but it can be really helpful for the pharmacist to develop a feasible administration schedule, to select agents that have appropriate stability if you're going to be doing something like extended or continuous infusion, and then what monitoring or labs is going to be feasible and who's going to follow up on that. For NTM, there are a lot of drug interactions, and especially with the CFTR modulators, they tend to be very resistant organisms, and so you really have to tailor the therapy based off the patient's individual cultures. And then they can be very difficult to tolerate. So I think that a lot of us might think of things like nephrotoxicity or ototoxicity as being the troublesome things. But if somebody's having really debilitating nausea and vomiting from one of their oral medications or IV medications, that can be just as harmful. So trying to work with patients to see if we can improve their tolerability, because they're going to be on these therapies oftentimes for upwards of 12 months. For allergic bronchopulmonary aspergillosis, patients who are on azole therapies, we can screen for drug-drug interactions as well as adverse effects, and then educate them on appropriate administration. So even for the same medication, different formulations have different instructions regarding take with food, take without food, and then some of them can just be difficult to get a therapeutic level, even in the best cases. So you just want to keep a close eye with therapeutic drug monitoring and making sure they're on the right agent. And then off-label use of IV antimicrobial agents. So in addition to helping with insurance, a lot of patients are going to need education on how do you prepare the vials for nebulization? How do you reconstitute? How do you draw back the solution and transfer it into the neb? What time is safe for you to do that? How early in advance do you need to reconstitute the vial? So all of that can be covered with the pharmacist. Pharmacy metrics can be helpful to justify adding a pharmacist, but also sustaining that funding for the program. And so basic pharmacist activities can be tracked either manually or using your EMR based on how many patients are being seen, what education is being done, and then other clinical interventions. We also can try to track changes in clinical data. We do want to recognize that that is very multifactorial, so you don't want to have that be the only thing that your program is hanging on, because you just can't put all of your eggs in that basket. You want to show some of the other pharmacist activities that you're doing. We can also look at medication access metrics. So there are two common metrics that are used to look at adherence. Medication possession ratio looks at the day supply sum for all of the patient's fills over the number of days in that period, and it's changed to a percentage. And this can potentially overestimate adherence in some patients if they fill early. So I think a lot of places are starting to move towards proportion of days covered, where it's the number of days in that period that are covered by the medication over the total number of days. And so this makes an adjustment for when would that patient run out of that first fill, even if they fill it early, so you don't get an inflated days covered and you can't get over 100%. We also look at how often are we calling insurance companies, prior authorization volume and turnaround time, and how many patients are we signing up for copay assistance or other grant funding. Health system specialty pharmacies can definitely be attractive for some institutions, and so looking at prescription volume, prescription revenue, how fast we're able to get medications to patients, especially if we're wanting to do something like eradicate Pseudomonas with inhaled topramycin. That data can be really important. And then patient satisfaction surveys. The role that we've discussed previously is really the traditional role of the CF pharmacist, and this is still vital moving forward. I did want to spend some time talking about some of the extra clinical roles that the CF pharmacist can have, whether that be guideline development within your institution, optimizing your electronic medical record, helping ensuring medication access during hospitalizations, so whether that be adding medications to formulary or even just helping with therapeutic substitutions while they're there. Or maybe, you're one of the brave institutions that's added CFTR modulators to their formularies, and you got to figure out how you're going to get it out of the packaging and get it safe to each and every patient. Pharmacists can be involved not only clinically, but also operationally, and making sure that things go smoothly in the inpatient setting, and then working on research. Some other clinical opportunities I did want to highlight are that some CF pharmacists engage in collaborative practice agreements, and this is an agreement between the pharmacist, a group of physicians, and is generally recognized by the state, and it gives that pharmacist the ability within a certain scope of practice to modify therapy, potentially discontinue therapy, and order various labs or other things that they need in order to safely manage that therapy. You also can work with your patients outside of clinic. So I think a lot of us do this where we answer drug information questions directly with patients. We get on the phone and answer their questions or guide them through medication access, troubleshooting even without a collaborative practice agreement, really being that medication expert for both the patient and the team. Guidelines that you can look into developing include a standardized dosing for your outpatient CF exacerbation, so that either doctors or nurses or other support staff are able to quickly identify what would be an appropriate dose for a patient. Especially in pediatrics, you might be able to also show what formulations may be appropriate based on the drug, if it's something like Augmentin, or just based on the patient, based on their age. We can try starting to figure out the simplified data and see if we can standardize when should we de-escalate therapy. Is there a pathway we should follow, or should we make it really patient specific? I think those are conversations that we've been having. Is there a pathway for when you should initiate certain inhaled therapies at a certain age, or other factors. So those are things you can work to try to standardize. And then CFTR modulator dose modification. So we know that there is some information available in the package insert for CFTR modulators, but I know most of us are also being creative and doing things to mitigate side effects. So is this something else you could also formalize for your providers and for your team? You can optimize your electronic medical record so that it works with you and for you. So standardized note templates are very common for visits and education. You can also develop clinical tools that help you track metrics. And if you know your EMR well enough, a lot of times you can be doing both things at once. You can be documenting as well as collecting data at the same time. And then you can optimize outpatient medication orders. So you want to create order panels. You can have appropriate dosing buttons pre-selected and order instructions available. There's also a great opportunity to collaborate on quality improvement projects with your CF team, whether it's related to medications or not. So I know that in my own experience, I've done quality improvement related to CFTR modulator monitoring, whether it be LFTs or eye exams. You can also just look at general things of how well are we preparing our patients to transition to clinic from the pediatric to adult clinic. Do they have access to care? Are we addressing reproductive health? These are all projects that you could be looking into in addition to many others. For different research, you can be looking at the safety and efficacy of different treatments in our patients, pre and post CFTR modulator studies, and PK, PD, or adherence. There are a variety of different publications that you can look into doing, whether they be as small as case reports or as reporting the results of your research or implementing certain clinical services so that other people can duplicate your efforts. That's all helpful for the CF pharmacy community. You can participate in various CF Foundation committees, and you can also collaborate with other CF care centers. So the Cystic Fibrosis Pharmacist Alliance for Research and Collaboration is actively working on several different projects, and this allows CF pharmacists and technicians across the country to collaborate, and so that we can all be working together so that we can have lots of initiatives be successful at once. And I've had a great experience and would definitely recommend it to anyone in this room. There are definitely some barriers to implementing CF pharmacy services. I think a lot of us first think of finances. So how are you going to fund that position, especially if you're looking to have multiple people, a pharmacist and a technician? It can be hard to get institutionalized support or institutional support, especially depending on the size of your CF center. Pharmacy administrative support, so convincing your pharmacy department that out of all the FTEs you get, especially if you're going to be a specialist, that CF is an area that needs one, and then making sure that providers have adequate pharmacy expertise so that they can serve the patients in the best manner. So there are a few resources from the CF Foundation I did want to point out. So we have the implementation of outpatient pharmacy services grant. It's currently in its third cycle. And there are the mentorship programs for both pharmacists and technicians. So the implementation of pharmacy services grant promotes development and implementation of outpatient clinical pharmacy services at accredited care centers, and it helps provide salary support for either a pharmacist or technician, and your award amount is based on how many patients you serve. You should justify your budget and your application and talk about what your strategy is going to be to providing these services. You want to be able to successfully integrate those team members into the CF care team and then assess the impact of pharmacy services. And then you'll need to submit annual progress reports in order to receive funding for years 2 and 3. The mentorship program is a great experience for mentors with 2 or more years of CF experience to be paired with an apprentice who's working to establish their role in CF. The goal of the program is really for either the pharmacist or the technician apprentice to learn of the different CF pharmacy resources that are available, to develop individualized goals for their on-site visit, and then observe some of the basics of CF pharmacy care through this site visit, and then interact with patients, families, and other members of the CF care team so that they can start thinking about how they want to integrate themselves into their own care team. So in conclusion, the benefits of dedicated CF outpatient pharmacy services have been well documented, and metrics can be very useful to help objectively describe how pharmacy services can have an impact, and that can help you secure sustained funding that you need for your staff. CF pharmacists can work to continue to expand their impact after they've mastered the basics of the traditional role through involvement in extraclinical activities within their institution or collaborating with the CF community. And you can look to the CF Foundation for financial resources and professional development opportunities for new pharmacy practitioners. Thank you so much for your time.
All right, we're coming down the home stretch, you guys. Hang in there. All right. So it's a great pleasure for me to introduce our final speaker, our closer, Billy Simonson. She's the Enhanced Access and Care Technician at the University of North Carolina Medical Center in Chapel Hill. She's my technician. Nobody can steal her. And so she's primarily caring for pediatric CF and pulmonary patients. She began her career in Mooresville, North Carolina at a retail pharmacy in 2007 and continued growing her skill set and knowledge at various retail locations before accepting a position at an all-service pharmacy, and that included inpatient and specialty medications. Billy's experiences allowed her to obtain exceptional knowledge and expertise in pharmacy and has allowed her to efficiently navigate medication management and insurance processes, thus ensuring that medical professionals receive the necessary support and that patients receive the best care. This ultimately led her to a position with UNC at the Medication Access Team, and over time, she gained experience in several areas, further improving her expertise until finally accepting a direct position with the Pediatric Pulmonary Team, which was actually funded through the grant that Dr. Ambersia just mentioned. And in her spare time, Billy is a mom of two and a wife who loves to explore other cuisines with family and friends and go kayaking. So thank you, Billy.
Thank you. Thank you. So I'm going to be presenting the next chapter in our playbook, the role of the CF technician in medication access. For this presentation, there are no relationships to disclose related to the presentation. The objective here is to delineate the typical responsibilities and functions performed by specialty technicians, to identify the manufacturer assistance programs and third-party grants, as well as standard benefits and enrollment information. And then also, we want to develop enhanced roles and responsibilities to optimize technician support within the CF care team. Just a little bit about me. I've been a pharmacy technician for the past 16 years, primarily retail. I did work for a short period of time in an all-service pharmacy. They serviced solid organ, bone marrow transplant patients for the adult and pediatric side. We did specialty medications, hospital discharge, and fertility. And then when I moved to the medication assistance program, I specialized in pulmonary, rheumatology, allergy and immunology, endocrinology, and some neurology. And then on the adult side, I did rheumatology, pulmonary, and transplant occasionally. Currently, again, my role is with the pediatric pulmonary group as a more direct role. And so I wanted to go over kind of a traditional role that you would see probably with a pharmacy technician. I want to keep in mind that this is probably a short list of all the things that pharmacy technicians do and all they go throughout the day. But the first thing that they do would be record keeping and documentation. This is a large piece in any kind of retail setting that you would find. It's very meticulous. You know, all the prescriptions that get written, and you have to make sure that you have copies and they're filed in the appropriate places. They also help with the prescription processing, medication management that includes scheduling, deliveries, script translating, insurance processing, medication fulfillment, and compounding in some cases. And then they also help with tracking and managing that inventory. And then the roles that you might see within the clinic would be completing benefits investigations, submitting prior authorizations and appeals, and conducting provider courtesy reviews, and facilitating peer-to-peer reviews with your providers. You would also seek resources or programs that can provide financial assistance with prescription medication copayments, and assist patients and providers in completing applications for free medications and submitting them to manufacturers on behalf of the patient. So you're really just trying to make sure that, that extra layer of support for those patients are there when you're in the clinic. The next here is easing that financial burden for patients. We wanted to list here some of the copay support programs available for CF patients. The first here is Vertex GPS, which of course is our modulators, Trikafta, Orkambi, Symdeko, Kalydeco. The next here is Pertzi. I did note that there is a new standard card for the Pertzi program, so it's changed a little bit, and if you haven't checked in on that, just note that I think you need to call the program and they'll give you a standard card, or you can go right online and just print the card. And that just is a little different from before. I think there was a lot of paperwork involved. The next up is the ZenPep Live to Thrive program. That program specifically, you cannot help the patient sign up. They do have to do that themselves. But you can go ahead and send them the initiation email if you have their email. For Creon, there's the CF Care Forward program. You can absolutely sign up your patient for that program and get them a copay card. They also have vitamin and supplement support there. It does require that they create a login, and so we do facilitate that and help them with that. There is also the Pancreas Engage program, which I haven't had too much experience with, but in the couple experiences I have had, they don't offer a ton of support. I think it's $100 per fill, whereas some of these other, it's a larger, heftier amount. I think for ZenPep, it's $2,000 a month, and Creon is $8,000 per year. So that one's quite different from some of the others. The next here is the NUSRA copay support and Caseton Access program. You also have the Air Cares program. And then along that lines, we've got tobramycin copay card. And I wanted to note for that one in particular that there used to be 2 generic copay cards. However, they have only moved to having 1 now. And so that is only for the Teva brand generic. So when you're talking to your pharmacies and you're utilizing that copay card, you do need to make sure that they can obtain that particular manufacturer. Otherwise, you can't use that copay card. And we've run into that a couple of times where the pharmacy just couldn't get the Teva brand or they had to order it special. Next up here is the Toby Podhaler and Neb solution. Another thing to note with that one is when you're on the Toby Podhaler website, it does not actually say that the copay card listed is for both products, but it is for both products. One that I am less familiar with is the Bronchitol through the Chesy Care Direct program. Since I'm peds, we don't do that one too often. And then I put the last here as the Pulmozyme copay card program. Next up here is grant programs. I wanted to say here that I put the program. There is a maximum award amount for some of these, and then I've got some key points for these. Unfortunately, some of these there are not maximum amounts for just because the programs don't have them listed or it's unclear how much they do provide. And sometimes it's based on what the patient needs. So first here is the HealthWell CF treatments. Unfortunately, that one is currently closed, and I know that we all hope out for it to reopen periodically maybe or later down the line. And then we've got the HealthWell CF vitamins and supplements. It is open and still accepting applications. The third here is one that maybe people aren't as familiar with. It's the HealthWell Peds Assistance Grant. The thing to note here is it's a phone application only, and the phone times can vary, but there are only certain diagnoses covered. For those, the ones we wanted to note here was the chronic bronchitis, the lung disorder, and the pulmonary disease. But there are lists of other diseases that grant covers, and we've successfully gotten patients connected with that grant and signed up for that support as well. We've got Piper's Angels here, Cystic Dreams, the Boomer Eason Foundation. That one in particular noted that it was only for CF patients who have received a lung transplant. And then I think a little earlier in the year, the Patient Advocate Foundation opened up, but right now it is currently closed. And then along that lines, they have another grant through the Patient Advocate Foundation. It's the CF Health Equity Fund. It's only for CF patients who live within certain zip codes. So you do need to go online for that one and make sure that your patient qualifies based on where they live. But it's pretty easy as far as putting in their zip code and making sure that that is something they qualify for. The next here is Claire's Place Foundation. This one, again, some of these might not help with medications, but I wanted to make sure, especially with Health Wellbeing closed, that we put as much out there as we possibly can to support patients, because we might not be able to get a medication covered, but if you can get a hospital stay covered, that still alleviates a financial burden. So this here is for a bill that is a hospital stay that's 14 days or greater. And so that's an option to help patients. The next here is the Bonnell Foundation. They allow 1,000, but I wanted to note here that they allow it in 2 increments. So it's $500 allowed twice. Another here is the United Healthcare Children's Foundation. They have a $10,000 per lifetime maximum. And I also want to note that it's for patients who are 16 and under. So it's a little bit different from, I think, the Pete's Health Well Grant, which is 18. Next here is the Oracle Health Foundation. That's for patients with no insurance for the requested expense. And then we've got Ellie's Army Foundation. And that assistance is only available to citizens that are in the U.S. under the age of 30. And then lastly, here it's the Assistance Fund, and that is currently waitlisted. Next up is adapting pharmacy technician roles for the future. Adapting beyond the traditional roles, what that could look like is individualized patient assistance provided in the form of either face-to-face consultations or virtual healthcare sessions. We can assist patients in understanding their insurance coverage, educating them on the available pathways for medications, and preparing them for the potential copays that they're going to face. We can also support patients through open enrollment season, talk them through their benefits, go over their booklet with them. We also do proactive prior authorizations and grant support because you can proactively do those things and monitor those things and avoid fires within your clinic. We've successfully done it within ours, and it works really well to create an environment that when there is a true emergency, you can actually address it because you don't have 13 fires, you might just have one. And then facilitating smooth transitions of patients from pediatric to adult care or from inpatient to outpatient care. Another option for adapting beyond the traditional here is assistance regarding formulary substitutes and recommended pharmacy options. So one of the things that I often do for my providers is I will tell them, hey, the generic's not covered, but the brand is, right? And I know that because, I've done this for so many years. So I'll key up a script, I'll send it to you, and then you can approve it once you've looked over it to make sure everything's accurate and send it over to the pharmacy. And that causes a whole lot of less headache for the providers and for the pharmacy. And it just removes that obstacle from causing issues down the line. We can also assist healthcare providers in managing and successfully navigating the appeals process. One thing I like to note here is that, through the appeals process, I know that all of that is such a headache, and it really does help to have somebody to be able to call and just ask questions about these appeals, find out more information, find out the intent of the denial, find out, what exactly that denial means so that the provider can then write a statement or write a letter that is well supported and it does make a change. I've seen it make a change in, the outcomes for patients. We can also collaborate with healthcare providers to draft clinical statements for prior authorizations and appeals by aligning with specific plan preferences, utilizing the language and considering the FDA labeling guidelines. We also can engage in conversations with plan administrators regarding established criteria of the plan. I want to say along those lines, we've seen in our state, they've instituted managed Medicaid programs. And one of the things that we really found through that was that these managed Medicaid programs were not aligned with the state properly. And we were able to make contacts and relationships with the people who are running those plans and have conversations with them about getting those items fixed or resolved so that the coverage between the Medicaid plans do function the same. So it's been a very good thing to do, is have those relationships and make those relationships. All right, and that brings us to the final buzzer, guys. Thank you.
Excellent. Thanks, Billy. We'd like to call all of our speakers back to the stage to field questions. As a reminder, please submit your questions to the Q&A section of the app, or if you're feeling brave, step up to the plate. And thank you for those of you that have already submitted some questions, but does anyone want to step up to the plate before we go to some of these? We should have got the foam fingers.
I guess so. We should have brought them. All right. I guess we can start with the first question. And this is a general question to the group. And I think we might actually punt it to Dave. So the question, though, was any insight on whether pharmacists or technicians may become a required rather than a recommended team member by the CF Foundation policies. And this particular individual stated that their pharmacy has been holding out on expansion because of their current pharmacy support, even though they have almost 300 patients due to the lack of wording from the CF Foundation.
Thanks. Yeah, I'm Dave Young. I'm an adult center pharmacist at the University of Utah, for those that don't know me. And this microphone's too tall for me, so I'm going to tilt it like this. So everything's too tall for me. But is this session being recorded? Oh, we should have a talk off the recording. But so in 2015, I got asked to present to the CF executive team, executive committee, plus the center director committee regarding the value of pharmacists on the teams. And I was the only pharmacist in the room, and they said, hey, Dave, come Bethesda, present your case, and you got 20 minutes. I was like, oh my gosh, I have to sum up 30, 40 years of CF involvement, pharmacist involvement in 20 minutes. It's a sink or swim moment. In my brain, I'm thinking it's a sink or swim moment for our profession. And my entire goal in that room was not to convince them how great we are. My goal was to convince them that they can't survive without us, right? And I highlighted a lot of the elements that were highlighted today as to the what and why and how and what we can do. And that then led to, and then I left the meeting. I had no idea how it went. And I'm leaving the meeting. I was flying back home to Utah, and I got a text. I was halfway to BWI, and I got a text from the senior vice president saying they just voted to put us as recommended team members in the document, which is huge. Because before, we weren't even in the document, so you couldn't take it to administration because we weren't even listed. But to answer your question, what's a politically correct way to answer this question? Our goal is certainly, I thought it'd be an amazing accomplishment if we could just get in the document, and I thought that'd be the end goal. And that's not the end goal, really. The end goal is to be required, right? That would be amazing. If every center in the country could have a pharmacist and or pharmacy tech, that would be amazing. And all the work that you guys do every single day has really been driving that agenda and providing that support. The grant program that I begged and pleaded for, the foundation's been 100% behind us. It's a third round. And I think you showed the one slide. So in this most current round, the 2022 to 2025, there was 25 centers that got funded. So we are, there's about 72% of centers that now have pharmacists or technicians in some way, shape, or form. What that means, we've been climbing up the hill of change like this, And, on change graphs, like you got to get over the hump and you got to get on this side of the hump, and then it's just kind of like the norm. We're really close. That is a politically correct answer, sort of. So yes, the goal is to hopefully get into the required bucket. And I guess the PCS way I can say this is I think that's probably very likely in the not too distant future. Hopefully they didn't delete that part, Bruce, if you heard me. So. Does that answer your question?
Slam dunk. Yeah.
Yes.
Yeah. Thank you. Oops. All right. The next question is for Dr. Ambrosia. Regarding adherence assessment, do you have a standardized tool or form built within the EMR to document and track patient adherence? I'm asking all the questions about adherence and documenting in my progress notes, but it's really this person is struggling with determining the most efficient way to track it. Are you using a certain dashboard or a report?
Sure. So I think that it depends on my visit. If it's a quick check-in, then I'll normally just add in a few sort of casual adherence questions and just document what I find. However, on our annual assessments, I don't know if Johnny's still here, but he helped build a great tool where we can we're asking patients directly about adherence, like which are you struggling with any therapies? If so, which therapy are you struggling with? And then through the course of the conversation, we can figure out what category we might say that their adherence struggle is. And then we can also document out of a few options, what support did we provide them? And so that will allow our specialty pharmacy to be able to pull those metrics for the patients that we're seeing, but it does require us to use a specific template as a smart form built within Epic, our EMR.
Thank you. The next question, I guess, would be for Dr. Bullington, or really honestly any of the clinicians up here. For patients with worsening mood, is dose reduction for modulators the first thing you do? And how often do you resort to starting mood medications or referral to psychiatry?
So I can start with answering that. I think it depends on the patient. So some of our patients, especially that note increased anxiety, the idea of modifying their modulator dose causes them even more anxiety because they don't want to lose that lung function. So we do have some that are very willing to try to go down, especially those with higher lung function. But we do have a lot of our patients, especially those that before modulator therapy were teetering, in the FEV1s in the 30s or the 40s, that just really do not want to go down on those doses. In our center, our pulmonologists are willing to prescribe SSRIs and SNRIs. So that is a big part of my job that I help with that. And I know it's not that way at every center. And we were actually talking about it earlier, like at what point does it get out of my bucket to be able to help with some of those medications, especially as mental health becomes more complex? But I don't know if any of y'all have a different opinion. Similar.
I would say, too, just a couple things to add. I think that it is important to recognize, and I think we all do, just the confounding nature of CFTR modulators and the COVID pandemic hitting at the same time, and just knowing that mental health has become a great concern in this country, but also it is becoming a little bit more acceptable for people to talk about. So we do want to always just do a thorough assessment to see, what else may have changed in their life, just to make sure that we're not attributing it to Trikafta just because we can, trying to get a good timeline as to when it happened and what specific symptoms they're having. I have had some success in patients where I have had to make significant dose reductions once they're stabilized on other mood medications through their psychiatrist, I have been able to titrate them back up to full dosing. So I think that it can, just because they have to go on a dose reduction for a period of time and, it was beneficial, but once they're in a more stable place, you can work to optimize their therapy again.
One other comment I'll add to that. So one thing that we do in our clinic is on the day that we're starting a modulator, we have our mental health providers see them in clinic. We do our baseline GAD, PHQ-9. Now we're doing the preschools.
Symptom checker.
Yes. And so we tag team off each other. And then we also sort of do a 6-month follow-up where we go back and revisit that and sort of try to determine whether any behavior changes or mood changes are part of things just going on in life versus is it medication related, et cetera. So I collaborate with my mental health provider too, so that we both do an interview, because sometimes they maybe have a little bit more skill at it. But
Yeah, that's great insight. We'll just keep going down the line. Billy, if you want to come up.
Okay.
All right, the question that we have for you is, you mentioned a little bit about specific wording. So when you've run into roadblocks with insurance companies, what type of wording or escalation has been successful in your experience?
So typically when we see denials, specifically for our Medicaid patients, one of the things that they really point out when they ask you the prior authorization questions is how it ameliorates the disease, right? Or the patient's condition. And so I've found that when I work the word ameliorate back into my response, I get a better approval rate. But I would say even more so than that is the calling and asking as well, because not everybody has Medicaid. So calling and asking what exactly and why exactly they are denying it, because sometimes they just are very unclear in the actual literature that they send. So just asking them outright, what exactly are you denying this for and why, can lead to a lot more information than you think.
Awesome, thanks.
Thank you.
And this one's for Dr. Peters. So you had mentioned inpatient census is dropping or has dropped dramatically. So with fewer inpatient admissions for CF pulmonary exacerbations, how have CF pharmacist roles shifted, and have institutions adjusted FTEs or responsibilities accordingly?
well, I guess for me it's a little bit different because we never had a dedicated FTE. I was just part of the clinic and saw patients in the hospital. But I know some of my colleagues have talked about that their FTE allotment has gone down at their hospitals. So I've definitely heard it from others. I don't know if anybody else would like to comment on it, but I have definitely heard that they've adjusted FTEs for dedicated inpatient pharmacists.
Does anybody in the audience want to share their experiences with regards to that?
So is the Kentucky crew here? Where anybody from? So we did a survey years ago looking at what our pharmacists doing and where they're working and that sort of stuff. What kind of activities? So we collaborated with the University of Kentucky. Paige Grube is was a resident who then revised a survey that we had done in 2013 that you'd cited, rolled it back out there, sent it back out again, and definitely saw a shift. The shift now is from the acute care setting to the into the ambulatory care setting. That's where most people are working, and there's obviously some doing both. Again, that really helps, I think, drive at least somewhat drive that agenda to get support from the foundation in getting pharmacy care in those outpatient settings. So, it's having just said that, you can't forget about acute care, and I think you did a wonderful job highlighting that, because yes, they're coming in less, but that's actually making each of those stays more important than they've ever been in the entire history of CF, right? Like, because they're coming in less, you have to maximize and optimize your antibiotic dosing and all that stuff while they're there to keep them out of the hospital longer, if that makes sense. So I think sometimes we forget about that, but I think it's actually more important than ever to do it the right way. We presented a paper in Europe regarding optimization of antibiotic dosing, not a paper, an abstract, and we're working on a paper that really highlights just how important it is to optimize antibiotic use for acute stays.
We probably have time for one more question. Does anyone in the audience? Otherwise, we can grab one more from online here. Seeing no one getting up. Okay. Dr. Imbergia, so I really like talking about adherence, but in your experience with pediatrics, how do you change your type of adherence monitoring or recommendations for different age groups?
So I think it's really important to get an understanding of attitudes towards medication from both the children and the parents, but then also knowing who is the primary person who's responsible for the medicines, because that can make a huge difference in your approach. So when they're younger, you really have to appeal to the parents because they're going to be the ones who are going to be able to implement that change. We can't expect school-age children to be able to manage the whole regimen on their own. It's a bit different when they're adolescents, and maybe they're a lot more independent. Maybe the parents couldn't even tell you what they're doing on a given afternoon after school because they work or for some other reason. So I think it's just getting that understanding and then trying to always make it individualized, whether you're doing it based on the parent schedule or the pediatric patient schedule. So whenever I get big red flags about adherence, I almost always start by saying, tell me about your day, tell me about your schedule. When do you leave for school or for work? When do you eat? When do you come home? Do you do anything after work? And then based on those sorts of questions, then I'm able to kind of narrow down. I learn more things about their specific barriers, and then I'm able to come up with a plan for them. And then it also helps me figure out like what support that they might have at home. It's also just, you don't want to place the blame on one party versus the other. So it can be kind of a delicate situation as well. So just kind of reading the room and gathering information and trying to make it a team-based approach for how we're going to make things easier for them, make life better for them, not we're going to get you to be doing the thing you're supposed to be doing. And I did just want to comment on the previous question. I'm in a hybrid role, and I think I cover the entire pediatric pulmonary service and not just inpatient CF. So I think that has led to some sustained support. And then I've also worked with my direct manager for when if I feel like the service is getting less and less busy, to like look at some of my other interests. Maybe I can support, antimicrobial stewardship in the outpatient setting and sort of use some of those transferable skills to still use that FTE to the fullest.
Absolutely. Thank you so much. Well, what a game. Can you guys join us in thanking our wonderful lineup of speakers again? And I don't know exactly for CE, but I believe those scanners in the middle of the room, if you scan your badge, you should be able to get your CE credit that way, like these little mini stands, is my understanding, is what somebody had told me. So don't quote me on that, but just so that you guys can get your CE. But thank you all for attending and participating. If you weren't aware, there is a pharmacy open forum and networking event at 5:15, so immediately right after this. That's going to be hosted in the building across the Sky Bridge in 211. So if you go across the Sky Bridge, go down one floor on the escalator, and it should be on the right. It's kind of a nook, is what Dave said. So it'll be a great opportunity to meet other pharmacists and pharmacy technicians from around the country. So we hope to see you guys there. Thank you for your attention.